morning. I'm Amy Smollers, Senior Director of Healthcare Education and Professional Development at the Massachusetts Health and Hospital Association. And on behalf of MHA, welcome to today's Executive Insight Series session. We are thrilled to be continuing this series, which has hosted nearly a dozen interviews with healthcare leaders on the most important topics facing our Commonwealth patients and caregivers. A few logistics before we will be recording this session for those who aren't able to join us live, and we will be in listen-only mode. If you have questions during the webinar, please place them in the chat feature. The questions will come directly to us, and we will do our best to address the questions today. Following the webinar, we'll be sending out a recording along with a brief survey. I also want to take a moment to thank our 2024 annual sponsors, as well as our strategic business partners for their support in underwriting MHA's programs. In particular, I would like to thank today's program sponsor, Robinson & Cole. Robinson & Cole is a full-service AM 200 firm with a vibrant healthcare practice, serving healthcare clients throughout Massachusetts as well as nationally. They are experienced lawyers trained to help clients meet their business objectives within complicated legal and regulatory frameworks. They are a valued partner in fulfilling MHA and our mission. I will now hand it over to Kate Healy, partner at Robinson & Cole, to say a few words.
Good morning, everyone. It's great to be here with you. Thank you to Amy and to Steve and all of the MHA. Robinson Cole is very pleased this morning to participate in the discussion with Rick Pollack and Steve Walsh. Steve, I'll now turn it over to you.
Thank you, Kate, and thanks, Amy, and thanks again to everyone for joining us here this morning. Today is kind of a special day and a unique one for us. It's our first ever national edition of our Executive Insight series. Since we started this series, we've spoken to more than 24 healthcare leaders from every corner of the Commonwealth. And we are lucky to be home to a world-class healthcare system here in Massachusetts. But our mission relies on advocacy at the highest levels of government. And that's where today's guest and our conversation comes in. Rick Pollack is the president and CEO of the American Hospital Association, where he serves as the top advocate for hospitals and health systems in the country. AHA is comprised of more than 5,000 provider organizations across the nation, and it brings its members together to collaborate around a broad range of clinical, policy, education, and public health issues. Rick began his career in DC as a legislative assistant for Representative David Obey of Wisconsin, then went on to serve as a leading representative for the American Nurses Association. And then in 1982, he joined the AHA. He took over as CEO in 2015. In the time since, he has helped advocate for providers through the most challenging times in our history, namely the COVID-19 pandemic, complex workforce issues, and extraordinary financial instability and challenges. But his work has also helped us define the next chapter of healthcare in the US, a mission that is close to our hearts here in Massachusetts. Rick has helped push forward new and innovative models of care, support the work of healthcare professionals, and center our collective focus around equity, affordability, access, and most importantly, patience. Rick, thanks again for joining us this morning, and thanks for everything that you and your team have done to support our providers, caregivers, and our communities.
Thanks, Steve, and thank you, Robinson Cole and Kate. But Steve, that was a very generous introduction, and I really appreciate that. But I also want to say it's great to be with you. And, you know, you are a great partner and a first-rate professional, and I hope that everybody in Massachusetts understands what a great leader you are. You're unbelievably connected. You enjoy the respect of your colleagues across the country, but also the folks at the highest levels of government in Massachusetts, and I've seen it firsthand, the respect of your congressional delegation. So thanks for having me.
Yeah, of course, and thank you for the kind words. But you have been at the center of federal politics now for more than 4 decades. So what originally brought you down to DC to work for Representative Obey, and then ultimately to move into healthcare specifically?
Well, it goes back to the 70s. And I went to the State University of New York College of Cortland, and I was a political science major. And SUNY Wide had a Washington semester program for political science majors from the different campuses. And I got selected to represent my campus. And they had an internship program down here. It still exists. And you can only intern for people that would give you a substantive experience. So it wasn't like you can go anywhere. And what attracted me to Dave Obey was the fact that he was a young guy. He was in his late 20s. He was the youngest member of Congress at the time. And I wanted to work for a young member of Congress. And that's where I started. And he hired me after that, went to graduate school and got a master's in public administration at American University. And he was an appropriator. And in fact, I met my wife in his office. We only overlapped for 2 weeks, but she went on and worked there for another 8 years. We're the only family to come out of that office. But he was there for like 40 years and became chairman of the House Appropriations Committee. And he was an appropriator. And I left to become a lobbyist for the American Nurses Association, having never dealt with health issues, never taken a course in health care. But as you can appreciate, as a former legislator, I knew the process. And at the time, the American Nurses Association wanted me to get them money for nurse training, still with us, money to start up nursing research as a discipline. And that's how I ended up in healthcare.
And so you talk about that advocacy experience and how important that is. I think sometimes we spend a lot of time educating our members, right, as to just how important it is to have those relationships and that ability to get things done and those important programs that support our workers. But you have seen probably over your time a lot of shift in the healthcare environment, and you've had to adapt to those shifts. What are some of these fundamental changes in healthcare over the decades?
And by the way, before I answer that, you talk about relationships, right? The reason I left the nurses to come to the hospitals, because it wasn't challenging. Because every member of Congress either had a wife or a niece or, someone in their family that was a nurse, and everybody loves nurses, as they should. So it got to be too easy almost. So I came to a more challenging side of the healthcare equation. But, what's changed so much, of course, and I'm probably stating the obvious, is political dysfunction like we've never, ever seen before, and political polarization. There's always been partisan politics, but it's gotten to a level that has become, nothing like we've ever seen before. So that's changed because healthcare is a big part of the political debate. We're always in the middle of something. Second thing that's changed and evolved over time is health policy is really budget policy. It's all budget driven. And that changes the dynamics in many ways when you're trying to deal with policy issues. The third thing that has changed is that over the years, there was a focus on reform. And, there was a focus on reform during the Clinton administration. Even during the George Bush administration, there was a focus on incremental reform. And then, of course, we had the ACA with President Obama. That was 13 years ago. Nobody is really talking about big picture vision or big picture reform anymore. It's all very transactional, and that has changed. The other thing that has changed over the last 13 years is the ACA now is, despite the rhetoric that you hear, it's here to stay. It's a building block for many policymakers. And, I don't think we're going to see repeal and replace. That rhetoric may be out there. But think about Medicare and Medicaid enacted in 1965. We're still amending it and perfecting it. I think that's where we are with the ACA as well. The last thing that has changed a lot is the role of litigation. Given divided government, which now is sort of the pattern, if you will, the executive, regardless of party, pushes the envelope to get things done through regulatory action because it's hard to get legislation done. That results in a lot of litigation in challenging the overreach that often occurs through regulation. And it's amazing how many things we're involved in now. We were involved 340B, went to the Supreme Court. We were involved on pricing transparency. We're involved on EMTALA as an outgrowth of the Dobbs decision, and we may see a Supreme Court decision on that this week, where we're very concerned about nurses and doctors being put in jail for, using their medical judgment. We're looking at the FTC's non-compete clause, litigation there that we're a party to with the Chamber of Commerce. Online tracking, that's another litigation issue. The nursing staff ratios for long-term care. So litigation has now become so much more prevalent in our advocacy toolbox and a necessity in the environment that we're in. That's different.
Yeah, and
And it's expensive.
It's expensive. Yeah, as a member that tries to support those causes, we know that, albeit important. You and I have talked about how litigation has to be part of the long-term strategy, but you talk eloquently about these policies, and they're important. So you can have a policy discussion with anyone, but it strikes me that often advocacy is not about policy anymore. It's so much about the personality and the politics and underlying philosophy. And when you started 4 decades ago, no one would hold it against you that you worked for a well-regarded Democrat. I see that's probably different today. How does the advocacy approach have to evolve when you're really in the middle of some thorny personality fights and some real challenging times in DC?
It's a great question. We are a bipartisan organization. I often say we'll take help from anybody that will give it to us. And I know that, here it's a lot different than in the Commonwealth for you all in terms of that political balance. But we try to be constructive. We try to operate out of the middle because we want to get things done. But that puts you in an unusual position. Being in the middle, as you know, is not an easy place to be. And you're never viewed as necessarily being on anyone's team in a very partisan environment. But we still believe, given the diversity of who we represent, we have to be bipartisan, and it's the right thing to do. So that's our approach. So when you see us taking on an issue, we always try to make sure we have a Republican and a Democrat carrying the issue. You look at, and as an example, the violence issue and the SAFE Act to make it a federal felony crime to assault a healthcare worker. It's Marco Rubio and Joe Manchin in the Senate, and it's a Democrat and a Republican in the House. I mean, we always try to frame it that way. But the other thing that I think you're getting at is how has things changed over the years in the world that we're in when it comes to advocacy that we're both heavily involved in. And I would say that, there are a lot of levers of influence that you have to press on. And I know you know this stuff well, Steve. But, the basics still exist. And the basics of lobbying, whether it's relationship building and being visible and being around the action as a resource, that's still there. Data, basic arguments, grassroots, coalitions, offering ideas and alternatives, that's there. What's different, though, is the emergence over time of grass tops in addition to grassroots. The emergence of having to frame issues in a politically attractive 30-second soundbite world. The use of advertising. I mean, when I first came to AHA, we didn't do advertising. In the late 90s, we got into that game. Being a convener of events is a way to influence things. Obviously, PAC and money is an important part of participating in the environment. When I first came to AHA, our PAC was in its infancy. Self-regulation is another interesting dynamic that has changed over time, where if you see something that is a legitimate problem, and if we don't take action on our own to deal with it, something worse can be imposed on us, is another level of influence. So whether it's billing and collection practices, reporting on how we handle 340B funds in a transparent way, that's being self-regulation. So all of these new levers over time have become much more prevalent than when I first came to this lobbying business.
Yeah, I've seen you do some remarkable work even around, it used to be there might be 2 parties debating an issue. Now you've got third-party influence on money that is shaping that issue. And it's kind of wild to see how you've had to change, because you're not only fighting the arguments on the inside, but you're fighting these groups on the outside that are up on television, putting massive amounts of money into a position. And oftentimes it's not a position that's going to help patients, and certainly not poor sick patients in the country.
Yeah.
So you've rattled off a number of them. I know it's a busy time on the Hill. Is there a top 3? Do we have the 3 most urgent issues? Is that too hard to define? But what are the top 3 in the AHA as this legislative session is winding?
Yeah, I would say a couple of things. First, there are things happening even this week. A congressional resolution to overturn the long-term care nurse staffing ratios, which is really a message vote. And as you know, in this environment that we're in, there are a lot of messaging votes. It's not that things are going to happen. It's the fact that people want to be prepared to, have a 30-second political ad on it. So that's happening this week. We could see the Supreme Court decision on the EMTALA case related to Dobbs come out on this week. Thursday is the day they issue decisions. But when you look at this year and what's coming at us, regardless of the outcome of the election, we're going to have a legislative lollapalooza, I suspect, in the lame duck session after the election. And I say lollapalooza because there are a lot of issues on the table, and the political dynamics could be very, very different after the election. But I would say the most urgent issues for us fall into three buckets rather than three issues. The first bucket are the funding issues. And a lot of the reason that the lame duck is important or is going to happen is because there are forcing events, as I said before. The government runs out of money. They only did their continuing resolutions through the end of the year. There are expiring provisions that need to be renewed by the end of the year. The debt limit may come up at the end of the year. So all of these are forcing events in the lame duck session. So the three buckets: first, general funding issues, Medicaid dish payments. There's an $8 billion item there. We have to prevent the cuts from kicking in. We've done it for like 13 years. And we want to obviously continue to keep those cuts off the table. Medicare physician payment this past January, there were Medicare cuts for physician payments. They were ameliorated by about half. That amelioration, if you will, or mitigation, it only runs through the end of the year. So that needs to be dealt with. So those are two big funding issues. The second bucket are extensions. There were a series of public health type extensions, public health waivers that were put in place, or pilot projects as a result of COVID. Those expire at the end of the year. Hospital at home, telehealth, rural provisions, the Medicare low volume adjustment, the Medicare dependent hospital adjustment, those need to be renewed by the end of the year. Then the third bucket is, as they put these things together and other things together at the end of the year, they're going to look for offsets, things to offset the cost of these other things. And that's where site neutral comes in. And that's the third bucket. So those are what we have in front of us. And they could spill into next year as well, for sure. And next year, by the way, there are two gigantic issues coming down the pike. One is the extension of the Trump tax cuts. They expire. That's like a $4 trillion item to extend it. And then there's the expiration of the ACA tax subsidies that were enhanced during COVID. That expires. Those two issues are really big ones that are going to come together next year. So that's what we have in front of us.
Yeah, I appreciate your education on that first bucket. That's the hard work that your team does that flies under the radar, that nobody knows how important that is for patients and health systems and our post-acute centers. And the second bucket impacts patients. I'm not sure patients know that telehealth might go away, hospital at home, these programs that they work. They're just great that were stood up during COVID. So thanks for continuing to fight on those. Anything that we should be watching, flying under the radar, that you say your constituents in Massachusetts ought to know?
Yeah. And by the way, on some of those issues I just mentioned before, there's a lot of bipartisan support going back to the way we frame things. Telehealth, the extensions, that's bipartisan. Medicaid dish, stopping those cuts, that's bipartisan. So on the issue of things flying under the radar, the thing, and it's a more global issue that affects us and it drives some of the stuff that we see happening, has to do with a general lack of understanding among the policy community, particularly the folks on Capitol Hill, about the cross subsidies that are out there as policy levers to compensate for the crazy financial model we have to deal with, where you have chronic government underpayment. And there are these policy levers that a fellow from Massachusetts, or that you all know well, Stuart Altman, used to call rough justice. And he called it that when he was the chairman of MedPAC, the advisory committee. And what's emerged is a lack of confidence in whether these cross subsidies are truly being used for the purposes that they were designed. So look at the three that we really rely on as rough justice, okay? Indirect medical education adjustment, which compensates for the fact that education is inherently, and this is a big issue for you all because of the teaching hospital presence, education is inherently inefficient. So the notion of having an adjustment for academic medical institutions to compensate for the additional cost of education, not to mention the acuity of care that occurs in teaching hospitals, is a legitimate cross-subsidy. That's less on the front burner, but because it's big, it's always kind of out there and on a menu that pops up when it comes up for offsets. 340B is much more hot. And again, technically, it's supposed to be, kind of the rough justice to spread the scarce resources we get from the federal government. But there's a perception that it should be used only for discounts for poor patients at the counter when they get their prescriptions. Now, a lot of it is used for that, but under the law, it was always intended to be broader than that, given that it is a cross-subsidy for so many other things that we do to serve our patients and communities. Yet that is under fire. And it's, again, a reflection of a lack of understanding of the reasoning for the policy in the first place, and a questioning of, is it being used for the appropriate purposes? And then the third is site neutral. The reason that we get that differential is because we're open 24/7. We take anybody that walks through the door. We have to have the standby capacity that physician offices and surgery clinics and freestanding centers don't have, that are not connected to us. We take care of a patient profile that is generally sicker, generally, poorer, and that's why we deserve the differential. But that's under fire because of people that look at an economic model of saying, hey, same place of service ought to get the same reimbursement. So that's sort of what is driving a lot of these things. And I think that this whole notion of cross subsidies, lack of understanding, lack of why they exist, that's something we have to keep an eye on, because on all three of these issues, while we may not have them dealt with this year, they'll be back.
Yeah, I really appreciate the way you just explained those in a very concise manner. I want to bottle that up and take it to members of our legislature, right? Somebody 50 years ago decided we would underpay in certain areas, and any cut now is a revenue cut. These have been hole fillers over the years. So I will go back and re-listen to the way you explain those, and I will borrow some of that. So thank you for educating me on a few of those key issues. Let me make the understatement of the morning. It's a big election year, right? Yeah. And I think there's a lot of things in healthcare that we don't think about when we think about the presidency. We might think about choice or Supreme Court or other issues, but CMS and Health and Human Services and antitrust issues and National Labor Relations Board. What are the dynamics around healthcare and this power change when it comes to the presidency? And I imagine your team is all over this and what the impact could be beyond what anyone's personal feelings might be about the candidates.
Yeah. What's interesting is this is the first presidential election in a long time where healthcare is not front and center. We've gone through so many elections where healthcare reform or repeal and replace, those were big issues. Now, the only real issues, when you really get down to it, is the issue of women's reproductive services and prescription drugs. And in a strange way, on prescription drugs, Donald Trump, back when he was running for election, said that the drug companies were getting away with murder. Now they take different approaches, but they're both saying the same thing. Certainly on women's reproductive rights, that's a whole different story. And then, of course, in the background is always the issue of affordability. But, both parties are still locked into their basic fundamental philosophical framework. The Democrats, on one hand, want some derivative of Medicare for all. The Republicans, on the other hand, think so-called competition is the answer to everything. But here's the thing. People make policy. So when you go to the issue of CMS in particular, the thing to watch really is the people, because things don't always happen, as we all know, at the White House. They happen, as you suggest, at CMS and in other important places where real decisions are made that affect us and affect a lot of financial matters. So people make policy, and there's a whole government in waiting out there, and they will push that philosophical framework that I just mentioned before. That's, by the way, why transparency for quality and price is really, it's become kind of bipartisan, but it really comes out of that competition framework. Because, the only way people can so-called shop is if they have transparency. But, I think that you got to watch the people.
Yeah. And let's talk about people just for a minute. I think we have some great people in our federal delegation, and you and I had an opportunity to sit with Chair Neal, who, is a self-proclaimed top supporter of hospitals in the country. I think we'd agree. And then we went over to chat with Whip Clark about some of her priorities. And you and I have done those visits. And I certainly think we have a very strong delegation. But from your national perspective, how do you see the Massachusetts team here and the relationship that they have with AHA?
Well, let me start with the MHA team. First of all, you and your team are really an extension of us, but you're so important because you know those folks better than anyone. And you personally, Steve, I've seen you connect with them in a personal way. And I know that you have such credibility with them. So it starts at that level. But, the House outcome, which, conventional wisdom suggests it's going to flip, would suggest that, Richie Neal becomes chairman of Ways and Means again, and Catherine Clark becomes, I guess, majority leader. She moves up around. So there's that presence, and Jim McGovern is the ranking Democrat on the Rules Committee. So if you look at the House, you've got a lot of influence. And of course, in the dynamic that we're in now, all of those three in particular are real leaders. And you saw how the Democrats helped elect a Speaker of the House that is a Republican, or I guess save them. So the Democrats have more leverage than we've ever seen in the past. But those folks are major, major players regardless. And, so they're really important. And then on the Senate side, what's interesting is the emergence of Elizabeth Warren. Now with her, it depends upon the issue, right? But she was great in the hearing with Andrew Witte on United. She really took him on. And on that issue in particular, she's exactly where we would love everyone to be. We appreciate that. Now, having said all that, you are an all Democratic delegation, and we are in split delegation. So that's why you need us here at AHA, and your members, because we can go places, obviously, that you can't. And that's why this marriage is so important.
It is. And I've seen it with my colleagues and the way you work with my colleagues from Arkansas, Kentucky, Michigan, California, all over the country. And so at a small scale, I've been able to watch it as we try to move things on the local level with the folks I work with. Some quick hits here, just as we're coming. We could talk all day and we start to wind down. And I just want to get 30 seconds on the workforce. What's the top hit that you think AHA is working? I know you're doing so much to support the talented healthcare workforce. Anything you want to flag for us?
I would just say the SAVE Act is really front and center, on the violence issue,
yes,
because that's just so important.
Got to give our workers a safe environment, right?
Yeah.
Absolutely.
And then I would say there are really two buckets here too. There's what we can do to care for the caregiver as a field. And there's a lot that is in our own hands. And, that's why sharing best practices among our members in dealing with it are so important. Then there's the public policy front, which we pursue, whether it's more GME slots, whether it's more money. Nursing faculty is a big part of the problem. There just aren't enough. So many nurses to be are turned away because we don't have the faculty. Loan forgiveness, allowing qualified foreign health professionals to come. The thing that I'm concerned about, though, is on the public policy front, it's kind of incremental. And that's why changing the care model, and that's a piece that we really need to focus on, because we're never going to have enough of the workforce. We got to change the way we work to have.
You're carrying a lot of buckets, so that must be heavy. It's a heavy load to carry. You've mentioned a bunch of them this morning. Give us a 10 seconds or less. How do you unwind? How do you take a break from work?
Exercise is what makes me work, and that's really important. Now, we talked about earlier, I'm recovering from rotator cuff surgery, so I haven't been able to do as much as I usually do, which is why my wife and family say I'm more crankier than usual.
Never cranky. You and I can't answer anything in 10 seconds. We're incapable. Give us the one must-visit place in DC for anybody that's coming down.
The one must place is the Marine Barracks, and it's only about 20 blocks from this office here. And they have a Friday night parade, and you can Google it, Marine Barrack Parade. And if you're ever here, go there on a Friday night. You can get your tickets online, and it's for free, and it's a wonderful experience.
We're coming up on time, and I saw we had one question in the chat, but I want to ask this last question we asked to all of our guests for our emerging leaders that are on the call. And we'll give you the last word to close us out on this morning coffee. What's a great piece of advice you've gotten along your career journey that you can share with us this morning?
The best piece of, there's a lot of advice, but the best piece, one piece would be people are invested in things they help create. And if you bring people into the discussion and you're inclusive in that discussion, you can get better investment on the other side, in no matter whether it's internal, external. That's something I live by.
Rick, that makes sense because your life has been about relationships. You're so good at it. You're such a good person, such a good friend, and you are a tremendous advocate for the work of our members on a daily basis. I appreciate your time this morning. We stand as your partner through every challenge and opportunity that you're helping us navigate on Capitol Hill. And we are very fortunate and lucky to have you as the leader of the American Hospital Association during this critical time. For everybody that joined us today, thank you. We hope to see you back at an MHA education event in the coming weeks. We're especially excited to be hosting our 3rd annual Workforce Summit on July 11th. We'll be joined by Secretary Lauren Jones from the Executive Office of Labor and Workforce Development. You can learn more about that event and others by visiting our website, mhalink.org. I want to appreciate once again you spending your morning coffee with us, and we look forward to seeing you back at our next Executive Insights episode. Rick, truly a pleasure as always to see you. I look forward to seeing you in person again soon. Thanks for joining me this morning. Have a great morning. Thank you.